So without further ado, I'm going to introduce Sammy, as we call him. Sam Robert Brown needs no introduction. He's a professor of neurological surgery. But just for lineage purposes, he grew up in Florida, okay? Hard to believe, in Miami, and he went to public high school, Killian Senior High School, sort of a rough place to grow up, rough and tumble. It's now, I told Sammy, a magnet school. So yeah, see what when they have illustrious graduates like Sam Brown, it elevates the whole game. Sam went on to the University of Florida. He stayed in Florida and he got a degree in zoology, went on to get his MD and PhD. He was in the medical scientist training program of NIH and got his degree in 6 years, MD and PhD. Sam did his training in Utah with Bill Caldwell and John Kessel at the time, and then his fellowship in pediatric neurosurgery here at Seattle Children's with Jeff and I. And I remember about 6 months into his fellowship, I said, enough of this. You're going to be an attending now. And he became an attending. I'm the only fellow that's ever become an attending after about 6 months. We knew he knew what he was doing, and that hasn't changed in the 20 years he's been with us. He's a fabulous partner. I don't want to go through the 150 plus peer-reviewed papers. I think the important thing to know about Sammy that people must know on this telemedicine, excuse me, on this Zoom, is that he's an inventor and an innovator, and he's won countless awards there. He's been involved in he's spun out about 8 to 10 companies of his own, and he's been involved in about 15, and he's probably has about 15 innovation grants, whether they're NIH STTR grants or commercial grants, life science grants, or UW Coulter Translational Research Award grants. He works heavily with with the engineering school right here, and he, of course, his most famous company that he started was Visus, the #1 football helmet in the country right now. He's now on to Proprio, which is a virtual reality surgical theater sort of company, but I don't want to I've already taken 3 minutes of his time. So without further ado, our most famous inventor, Sammy Brown. Sam,
Rich,
thank you.
Rich, thanks a lot. It's been the greatest thing ever coming to the department here that ever happened to me. So I really do appreciate it. Let me get the talk spun up here for a half second. So can you guys see it okay, or do I need to swap it?
Looks good.
Okay, cool. So as Rich was mentioning, I've had the great fortune to be able to try and take technologies and spin them up within the university and move them out. And in the course of doing that, I've had a nice opportunity to kind of look around at what's happening out in the world and try and understand what trends are, because those become relevant as you spin companies to know who's the competition and who's thinking about things in different ways. And I think one of the things that has really come to the forefront for me over the last couple of years, in particular with the work that we've been doing with this one company, Proprio, that we'll talk a little bit about today, is that there's an evolution that's going to happen in surgery. It's happening in medicine, but it's definitely coming in surgery. And in particular, it's going to come to neurosurgery, where we're going to move from an analog to a very digital world over the next few years. So what I thought would be kind of fun today is to go through what I've been seeing out there and just some thoughts around the digital world, so that everybody can see at least some of the things that I've been seeing out there too. So everybody knows me and the couple things I've done. The disclosures for this, the only one I'm going to talk about in any way today is really Appropriate, which is a computer vision navigation company. I'll talk a little bit more about that, but these other companies are super interesting. Deepwell's looking at mental health and virtual reality, and Newfluent's basically a venture studio that we've developed for neuro innovation. So I thought it'd be fun to start here. So OpenAI is in the news every day, and I thought it'd be fun to type in who is Richard G. Ellenbogen and see what it does. And it did a pretty good job with that, actually. He's not the chief of neurosurgery at Children's anymore. That's Dr. Lee, but the rest of it was not too bad. Then I thought it'd be fun to put in Shekar's name, because I think of Shekar as like Madonna. It's one name in neurosurgery. Everybody knows him, and see what it did. And it didn't do such a hot job. And then I tried to give it a little bit more information and say, who's Shekar, the amazing brain surgeon? And it unfortunately came back with, however, there are many talented brain surgeons around the world, and Shekar could be one of them. And so, the technology, as good as it is, it's still not quite there. And so I want to keep that, kind of at the top shelf as we're talking through this stuff. So I'm going to talk a lot about where this is going to go, but there's work to get there for sure. So let's talk a bit about data. So data has been around for a long time, and people have had many comments about data. Some of these I thought were germane. So, Napoleon Wars 90% of information. Satya Nadal, in taking over Microsoft, everything's going to be connected to the cloud and data. All this will be mediated by software. Vinod Khosla is one of the most prolific venture capitalists in the Bay Area, and he said big data is going to replace the need for 80% of doctors. You can read a couple of these, other quotes, but data is a very important component of what we do every day, and it's only going to grow exponentially. And I kind of like this quote. It was, gaining knowledge is the first step to wisdom, sharing data is the first step to humanity, and sort of how we're going to share data, gather data, is really going to transform what we do. So I figured I'd be a little provocative in the talk today and throw out a couple comments, and people can agree or disagree with these, but I'll give you my rationale for it. So the first one, and I presented this at a meeting, and some people nodded and some people threw tomatoes, but the statement is all formative advances in neurosurgery going forward are going to be technology and biologically based. So where I come to this from is there's only so many ways to get inside a sphere, and we can name those procedures after each other and move an inch this way or a centimeter that way, but we've largely figured out how to get into the brain, and a lot of the technical aspects of neurosurgery have largely been solved. We're making minor tweaks, I would say, as we go forward. And so what this means over time is that training, research, how we operate, collaboration, it's going to evolve. And I went to a technology conference, and I got first introduced to this concept of the S curve of technology evolution. And what this means is that if you look on the left, there's sort of an arc to technology. It's kind of slow to start. It gains adoption and traction and advances, but then you get to a point where it starts to kind of peter out, and you've done about as much as you can. And so this came from an example of, photography, and then moving into digital photography. And so cameras, film, all that stuff's gone. And usually the first thing that comes in is probably not as good as the state of the art at the time, but it starts to advance and surpass it. And this is what I think is going to happen in neurosurgery. So I'm calling the current epoch analog neurosurgery, and where we go, digital neurosurgery. So just to level set, there's an immense amount of data that's being collected. So if you look at Epic, it's been around since '79. There's 250 million patients, 9 petabytes of data in various hospitals, and these are relational databases. And so if you look at a petabyte, just to level set, it's an immense amount of data. So we're starting to talk at the level of petabytes, exabytes, and even beyond as we're looking at data that's out there now. And the only reason this has been possible is, as Moore, who recently died from Intel just the other day, the cost of chips went down dramatically, and the amount of storage went up dramatically, and it enabled this entire technology revolution. Similarly, the cost of data storage has gone down dramatically. In 1980, it was $14 million to store a terabyte of data. looked at this a couple weeks ago, and at Amazon Cloud, you can spend $23 a month to store a terabyte. So it's enabled a lot of this data to move forward. And again, just to put a lot of this in context, if you look at every word that's ever been spoken by humanity, that's 5 exabytes of data. So we're talking immense amounts of data. And again, I like to try and wrap my head around these things. And so this was an infographic that I thought was kind of cool, that, just reading through a few of these things, 28 petabytes will be generated a day. And this is 2 years ago data from wearable devices, right? Which will be probably relevant for what we do. There's 3 billion emails sent a day. The amount of data that's getting acquired and transferred and moved around and how we're engaging is astronomical on a day-to-day basis. And if you look at data in healthcare, similar trends are present. So it's estimated right now that we're acquiring about 2.5 million terabytes of healthcare data a day. So that equates to 2.5 exabytes. So that's a number with 21 zeros after it. And 30% of the world's data is generated in healthcare. And each hospital is making somewhere in the order of 50 petabytes or more a year. There's an immense amount per patient. And if you look at the macroeconomics of this, big data in healthcare over the course of this next decade is going to amount to about $81 billion with a compounded annual growth rate of 19%. And people are starting to understand and recognize this. This is a look at healthcare publications, looking at big data that's occurred over the last couple of years. And it's just, astronomically increasing. So people are understanding there's data out there and trying to figure out how to use it and what to do with it. And I also have up here just an example of like an MRI of the brain is 100 megabytes, right? And as you start to acquire live data or, much more complex data sets, that just only increases, again, exponentially. So as I put the talk together, I want you to think about it in kind of 3 areas: knowledge, vision, which I would call kind of an input function, and learning. And these are all intersecting, so it's kind of hard to break it down by one group, but these are the common themes to take out of the talk today. So when we talk about AI, I look at it as the analysis of data at scale beyond human capability. Where I see promise here is this idea that as human beings, you can only make so many inferences and relationships. And even with standard statistical methods, I think it's challenging to take these enormous data sets and extract useful information from them. So the idea with AI is you can take these very disparate data that look very confusing and make some type of assessment or analysis of them. And there are a lot of catchphrases that are thrown around. Big data is one of them, but big data, again, kind of falls into this bucket of, as you're taking just massive amount of data, how do you reorganize it and then subsequently analyze it in an effective and meaningful way? So I like this graphic because to me it summarizes a bit of the complexity that we're dealing with now. And I was thinking yesterday when I was making this talk, my version of Greenberg that I had when I was basically an undergrad and shadowing like Roden and those guys was about 1 inch thick, and it was a tiny little pamphlet basically you put in your pocket. Now the world has evolved, it's immensely complicated. So if you look at what's out there, there's social interaction, there's genetic and molecular markers, there's all the data in the EHR, there's research that's going on that can inform the patient's care, lab studies, what medicines, diet, environment, and then this host of medical imaging. And on the imaging side, the comment I'll make is that we're really only scratching the surface of what data is actually embedded, like in an MRI, for example. So then you take all of those data streams and then you try and make some associations and inferences. So if you stack that data together, how do we ultimately extract information out of it that allows us to get to this point of precision medicine and all these catchphrases of how do you treat that individual based on the knowledge of the masses, right? And all of this data. It's immensely complicated. And as human beings, I don't think we're quite capable of assimilating this type of data. So this is where AI, machine learning, some of these things I think are going to be beneficial coming forward. So if you look at Wikipedia, it defines AI as perceiving, synthesizing, inferring information is demonstrated by machines. And typically examples put forward are speech recognition, which, you know, with Epic and all the Dragon, all these things, you can say what you want, but it's gotten amazingly better even over the last couple of years. Computer vision, which we'll talk about a bit, and a variety of other things. The Oxford English Dictionary similarly talks about, you know, what this is, but it's the idea that computers are able to perform tasks that generally have required human intellect or intelligence. So briefly about machine learning. So you will hear different terminology that comes up, and I definitely am not sitting here saying I'm the world expert. I'm trying to absorb and learn. And I saw that Christine Park, one of our incoming PGY1s, is on the call today. And, you know, people like her who are studying and learning these techniques are going to be immensely valuable to our profession. But in terms of machine learning, there's various ways of doing it: supervised, unsupervised, semi-supervised, reinforcement learning. The computer scientists are trying to figure out how to teach these algorithms and systems to extract this information. And so some of it can be more simplistic and traditional, where you're having an input and you're classifying data and there's an output. And then there's more complex things that are occurring, like neural networks, where there's portions of what the code is doing that we really don't necessarily have clear visibility into. And sort of how is that obtaining and defining these outputs, and are the outputs relevant for what we want to know, or do they make sense in context? So, you know, there's still a human that needs to be in the loop as these things learn and inform us. So machine learning techniques can pull out a variety of different things, looking at regressions, associations, feature extraction, clustering of different data. They can, you know, help with classification and prediction, a variety of different things. And so there's an immense amount of work in computational science going into these techniques. And, you know, everybody's talking about it. It's largely been focused in medicine to date. And so this was from a New England Journal article, but, you know, in healthcare, they're looking at obviously diagnostics. How are we using this to look at preventative medicine? I mentioned precision medicine. Medical research, an enormous amount of work is going on here, trying to look at genomic databases and, you know, with drug discovery as an example. There's a really interesting set of work that's being done around cost reduction as the hospitals are stressed, and we're looking for ways of reducing costs. These are immensely complex systems, right? And so how do you look at healthcare expenditures and where those, you know, happening? So cost reduction is a big thing for data. And then obviously population health. As you amass these huge databases, what can we learn about populations, and how do we better treat our patients? So where's this going, like realistically in neurosurgery? Like where's AI going to play out? So in the preoperative setting, this is already happening. So we're looking at risk assessment. There's a number of papers that have come out in our literature looking at understanding patient demographics and, you know, what are their risks going into surgery. Operative planning and approaches. I'll talk a little bit about what's shown in this picture here, which is called Metacrea. It's a company that Medtronic bought looking at spine surgery planning. It's super fascinating. I'll explain it in a minute. In the operating room, one area I've been very interested in is around computer vision and machine learning. Can we do scene identification and extract that information, where later on, and this is obviously many steps downstream, in surgery, you're going to start to get clinical decision support. The system will recognize what's going on and say, you know, if you do this or that, you know, that may be beneficial in this moment. So there's a long way there, but it's trending toward that type of thing. Post-operatively, there are folks working on automated outcome tracking. Christoph's very engaged in doing amazing work in this space. How do we engage with patients, leverage mobile devices, you know, in a variety of different ways, diagnostic tools, which is work that we're actively working on in other spaces, So there's a lot to do in the post-op period. And then again, this exciting big data opportunity. So when we talk about QI and QA, I think about it in terms of, 1,000 by 1,000 or 10,000 by 10,000 matrix. How do you arrive at either root cause analysis or what should be the best practice based on outcome? How do you dive into all of those different variables and extract out what is actually of value and of meaning? So our profession's paying attention to a degree. This was a paper that came out 2 years ago in JNS, and they called it the Field Guide for Neurosurgeons. Hopefully this talk is a little bit about that. And they listed a bunch of articles that have been published. If you were to run PubMed now, you would see hundreds of articles that are referencing AI, machine learning, computer vision. Our spine colleagues, I would say, are light years ahead of the rest of us at least publishing around databases in this way. I mentioned Christine earlier, but with Hotman and one of our colleagues at Ohio State, we're going to be using the HCRN database to do some of this work looking at outcome metrics around hydrocephalus, because they have a super good, very clean database that we want to leverage. So I mentioned Metacrea as an example where industry has also figured out that the widgets that we put in are all going to be sensorized. So they're very interested in the data, and some of them realize that the next rev for them is that data is going to be more valuable than the implants that they put in. And so Medtronic, being the intelligent company that they are, they acquired something called Metacrea 2 years ago. And what Metacrea was, is it's a company that had preoperative and postoperative x-rays of spinal surgery patients. And so they knew preoperatively what their imaging looked like. They knew what the surgeon did from the postoperative imaging and what constructs were placed. And they had follow-up information about how that patient did. So what they've done is they acquired this company, and now they're selling you a pre-bent rod. They'll take your patient data. They will try and come up with a couple operative plans, submit them to you, and then sell you a pre-bent rod. The endpoint here is not the pre-bent rod. What they're doing is they're acquiring data across the care continuum, understanding what the pre-op state was, what you did, what it looked like at the end, and what the outcome of that patient is. So all of a sudden, they have something that's immensely valuable, right? Because they can then give you some predictive assessment as that database grows as to what's the right thing to do for that complex patient. And if you look at this circle, the way they've envisioned it, it's, imaging analysis, case simulation, it's patient-specific implants, supporting you in the case. They collect more data, they process that data, they give you predictive models around the next patient, and then rinse and repeat. And this is going to tie into robotics. How are, the robots lining up? What's the best idealized screw placement? There's a lot that is here to unpack, but this is such an important example that I've seen out there for the way I think a lot of this is going to go. So I will say that big data and artificial intelligence will define the 21st century in medicine. I feel very strongly about that statement. And if you don't believe what I'm saying, maybe you missed this, but the UW just formed a medical data science institute focused on AI, machine learning, and healthcare. And I found out about this by reading GeekWire. So I don't know if the department's super engaged in this. I hope some of us are, but people have identified this, and the university is starting to engage in this space in an organized way as well. So kind of changing to vision a little bit. So how are computers looking, seeing, and subsequently acquiring data? So everybody looks at this picture, even though it's chopped up, it's Brad Pitt. And I picked Brad Pitt because apparently he has problems like identifying people that was published recently. I don't know if he has prosopagnosia or if he's, just doesn't want to, interact with people. But either way, you look at this picture and you go, this is Brad Pitt. So what are you doing? You're taking, features of his face, his eyes, you have this in your memory of what he looks like, and you process that. And similarly, in the operating room, you see this and you go, okay, these are Penfields, and I know what a 1 is, and a 2 and a 3 and a 4. And I can identify that because I've seen it. I know the shape, I know the texture, I know the contour of what the instrument is. So we can learn this. The assumption is that with computer vision, you can teach a computer to identify these things. So we all know on the left here, sort of how this happens in the brain, right? It's quite a complex system, but we've broken it down. We understand at least to a degree how this works. You bring that visual information in, it's processed, it's, run against your internal memory banks, and then you parse that into various features. Is it a person, a place? Is it a thing? Where is it in space? All of that kind of stuff, right? So it's a complex thing that's happened over millions of years of evolution. So many of you have probably seen this. I'm going to play this video because it's horrifying, but also really interesting, right? So this is Boston Dynamics robot. So this thing's doing parkour, and it's using computer vision to understand, what the scene looks like, right? So it can then take that visual input and guide the joints and robotics and coordination of this machine, right? And this stuff is advancing at a pace that's, unbelievable and scary. And, this obviously worked very well. And I'm sure they had a million failures with this, but it's an example of where the world is at and where the world is going. And, this may be the beginning of Terminator. I don't know, but it is illustrative for me around how advanced a lot of this stuff is getting at this point. It's pretty crazy. So, at a basic level, how is this working? So they're trying to simulate to a degree what's happening in human vision, right? There's inputs, you have a sensing device. It's trying to interpret these things and identify and break down what they are. There's a bowl, there's oranges, there's bananas, fruits, etc. So each of these things have unique characteristics. And if you can train the computers to identify these things, you can start to extract that information. Right now, these are very laborious things. When people say computer vision, there's usually a human being on the back end going, okay, computer, it's this. And you tell it that 10,000 times before it figures out how to do it. But these things are constantly improving. And computer vision is fascinating because it covers many different facets here. So there's image segmentation, object identification. If you go and you board the Delta flight at SeaTac now, they're doing facial recognition. You can opt in or out instead of showing them your boarding pass. Edge detection, pattern detection, classifying images. All of these things are within the purview of computer vision. And so again, what role do these have in surgery and what's needed to execute on these? So I'm going to give you an example where this has made its way very actively into neurosurgery. Mike Levitt and, all of our vascular colleagues are well aware of a company called Viz.ai. But what Viz.ai has been able to do is, as a radiologist would look at this picture and go, there's a large vessel occlusion, right? There's blood vessels on this side, but there's not on this side. It truncates here. We see a couple other signals in these other images. What they've been able to do with that is develop a program where they use AI to look at these images with a high degree of sensitivity and specificity. Then they use the outcome of that to spawn the care team. And the idea is that if there's an early look, an early understanding of what the pathology is, and we know time to treatment is super important, this program then has integrated the care team and the imaging and has advanced the rapidity or speed at which a patient gets in and gets taken care of. So clear value. They've made tremendous advances, this company, in only the last couple of years, and they're starting to branch out into a bunch of other areas and diagnoses that they're looking at. But it's a great example of computer vision and AI. I've been talking a lot at different meetings about black box. I'm not the first one, and our group's not the first to talk about the black box, but surgery, is an environment where we're teaching, learning, and all of that information is ephemeral. It just disappears, right? And there's so many variables that come into making the operative event happen, right? There's so many inputs here, right? the duration of training, who's doing the surgery, did you train in the US, what technologies are you bringing to it, did you train in private practice, or I'm sorry, are you working in private practice or academia, what patient population you see. There's a million variables that go into that operative event. All the stuff that we do inside of surgery right now is essentially lost, or it's handed off one-to-one, like tribal knowledge between the teacher and the student, or in private practice, it's just happening and it just goes away. But on the back end, if you knew what was happening in the operating room, you can do a lot with that. You can start to understand surgical performance. You can track inventory. You could potentially automate billing and coding. We shouldn't be dictating operative reports anymore. It's silly. So there's a lot of stuff that can come out of knowing what's happening inside. So people have recognized this, and there are a bunch of companies starting to work in this space. So this is a company, I believe they're out of Toronto. They're basically, if you look at this lower picture, they're doing computer vision image segmentation. This is with a laparoscopic image to identify the structures and track the operation. And so take it a step further, there's a company called Theator that's out there. The idea there is that they're tracking what you're doing in surgery. So if you're taking scissors, and in that case, you're going for the bile duct and you should not cut the bile duct in that operation, they're going to throw up a warning flag that says, hey, you're doing something wrong, stop. And while they're doing that, they're capturing all this real-time information and data, right? So what are the pathologies they're treating? What are the various surgical techniques that are happening? What tools are actually coming in? You know, there's a lot of interest right now in the back table, understanding what we're using. I probably use on a given case like 10 instruments, right? They flash or sterilize hundreds for every case. There's thousands of dollars wasted in every operation. So I'm going to share a little bit about some of the work that we did because it's germane to this particular question. So this is the company Proprio that we spun up out of UW about 6 years ago. The project started actually almost 9 years ago now. I was originally interested in VR and could we do a digital microscope? And so we basically took a bunch of different cameras. This is called light field imaging. And this is obviously a cadaver brain that we imaged. This is all digital, all synthetic, that you can capture these images, process them, and represent them in VR or whatever modality you want. And we realized in the context of doing this that we're actually topographically mapping the anatomy because you need to know where it is in space if you're going to represent it as an image that you may work on. So we realized we were doing real-time navigation in the course of this. So we started to work and build some of this out. This is Evie. She is a PhD in actually video games who was part of the company helping us in the early days with this work. And so we ended up developing a multi-sensor array. This has cameras, depth sensing, IR tracking, electromagnetic tracking, a bunch of stuff. And the idea with this is that you can shine this down over the field. It can look down on the field and accurately understand where that anatomy is, and then tie that back to preoperative imaging. In this particular case, it would be a preoperative CT. We're starting in spinal surgery for navigation. But the idea is that you can track the anatomy in real time, and all of this is digital information. And you know, there's analogs of this happening out in the world, right? So if you look at what's happening like with Tesla, for example, and how they're trying to develop autonomous driving, there's a lot of corollaries. So if you look in the background at what Tesla's doing, the car is just a sensor platform. And it's got cameras, it's got LiDAR, it's got radar, it has data that it knows kind of GPS mapping where you're at. And basically what it's doing is it's identifying and labeling all these different things, right? What's a car, what's a crosswalk, you know, what's the relationship of those to the car where you're at. And so these type of principles are going to come into the operating room, and we will hopefully be advantaged in a similar way to where ultimately things are happening in the non-surgical world. So here's an example of the way this may go down, right? So if you're taking a ML program and you're showing it a dog, it's going to basically break this down by pixels, edges, combination of edges, feature identification, And this combination of different things lead to a conclusion that that's a dog. So we're already doing that, right, with facial recognition, and that's happening in the real world. So if you take a rodent drawing like this, there are repeated patterns of anatomy. They're complex, but a lot of these things we know what they are, right? So they would avail themselves to these type of concepts as we move forward. And so this is an example of an image we took with the appropriate system. This is a porcine dissection. This is all digital information. So once it's digital, then you can do a bunch of cool stuff, right? You can render things on top of it, like we did that drill that you saw there. You can track as you, for example, do a decompression, know how much bone came out. You can layer on top of that navigation. You can do a ton of different things, or you can bring information to the surgeon in context while you're operating if you know what they're doing. So again, similar principles applying here. And it goes a step further. So recently been talking quite a bit about this idea of a surgical EMR. So we have Epic, we have all of that categorical variable data, the labs, and we have a lot of written text that now, you know, it's more possible to extract that information if you really go in and search that. But we have nothing in the operating room. So this is where there's an interesting opportunity around CV, which is, can you start to pull out information and populate a database with relevant information on that patient, and then build those databases and data sets over time. So in this example, like, we know what screw you put in, what manufacturer, what's the length and width of that screw, where did you place it, what were the angles that you took when you placed it, what time did you do it, what instrumentation did you use, what's the amount of blood loss that's occurring during the case, what other things were brought into the scene. So we have an IRB right now at UW where the system is sitting over the field, and Dr. Bransford's been using it. And in one of his cases, we identified 1,300 unique steps within that particular operation that he did. So this stuff is happening. It's just a matter of time until this becomes real. But I think, you know, like what happened with Epic in 1979, I think there's an opportunity for these things to happen going forward for us in surgery. So a couple other things, you know, is CV really just for data extraction, or can you use these concepts to actually perform surgery, or is it operant for us in the surgical room itself? So again, this is some of the work that we did. So what you're looking at here is a sawbones model that we took a CT of. And as you push the sawbones, the system's tracking the anatomy in real time and warping a CT back to that dynamically. So this idea that as the patient moves, or we're manipulating the anatomy or changing the anatomy, can you understand what's happening and update to that in real time, right? It increases safety, increases knowledge. We're extracting that information in real time as it's happening. So here's an example of some work that we've done. This was done at Seattle Science Foundation almost a year ago now. So small opening. For FDA, for us, we're still using markers, but these will go away. And what I want you to pay attention to is this frame up here. So the CT using machine learning has been segmented so that there's an individual vertebra. The green is where the system's tracking the anatomy, and then we can infer, because we know the geometry, the remainder of that structure. Now the light field's applied, and you see the skin and the bone and everything in situ as that cadaver is laying on the table. So whatever happened with positioning is accounted for here, and you can rotate that image and look underneath. So as you stack the vertebra there, you apply an MRI on top of it, you can see the anatomy of, say, a tumor. Not only can you track potentially the instrumentation and other things that are coming in the field and what's going on, but as a surgeon, you're going to have much more contextual knowledge about what's happening. You don't have to go, you know, step by step to then see and uncover that anatomy. You'll have more information as you go. And again, this is all digital. Here's another example of using it with some technology that we've been developing around, you know, tracking the surface and being able to use surface markers to do registration. And there's a lot of work to be done here, but again, How are we planning the surgeries? How are we visualizing stuff? One of the key things that we've been interested in is doing this without X-ray radiation, right? So how to use computer vision to obtain similar useful information that we get right now with ionizing radiation. And like, why do you care about this? So what are like relevant and real applications of it? So I am a part-time spine guy. Admittedly, I do the cervical stuff at Children's with my ortho colleagues, but I've been learning a lot about deformity surgery and this idea of a gap score. And this is a quote from a famous spine surgeon that they only get the desired correction about 30% of cases. And why that's important is that if you don't get a good correction, the likelihood of proximal junctional kyphosis or reoperation is significantly higher, right? The worse that score is. And it's really hard to know when you're doing these cases exactly how you've gotten the alignment. And so people will flora, they'll do arm spins, they'll do a variety of different things. They'll step out, they'll do a bunch of these complex measurements to try and understand what they've done in that operation. And so if you could automate this, there's value in that. And so we worked on this problem. So this is an example of a sawbones that's instrumented. There'll be a rod rotation maneuver. But what I'll call out here is that we imaged this and we're able to calculate on the fly the Cobb angles and also interesting things like neuroforaminal height, disc height on the fly, just based on being able to image this anatomy. So what you'll see is as the anatomy is corrected here, the system will shoot a new registration shot that in this example takes a second or two. And it re-registers the image, but more importantly, what it does is it recomputes all of these angles. So it goes from what's the pre-op to the current state with the correction, and you're looking at a variety of different measurements that actually do matter a lot in terms of the patient outcome, like what is the Cobb angle? Pre-post maneuver, lumbar lordosis, pre-post. So this is what these type of technologies are capable of doing. So I'm going to spend the last little bit of this talk talking more about VR and sort of, again, where data and some of this whole intersection is gonna happen. So VR is an interesting thing, and I've been talking for a while and probably pushing back these dates a bit, but my assumption is that we're all going to be wearing a VR headset in the operating room, probably for the entire case within 10 years. The reason I say that is for a surgeon to adopt something, it has to bring value to you in some way. Either it makes you better, more efficient, whatever it may be. There has to be some significant value for you to use it, and it has to be comfortable. And so all of those things are sequencing in a way that I think that it's going to be very, useful for us in the operating room. Form factors have improved dramatically and are only getting better with the billions of dollars that are going in. And the utility of these things and the information they're going to bring to us, I think, is going to be unbelievable in the next few years. And the other piece of this is that there's a trend that's happening now for the residents to pay attention to, where maybe not our current cohort, but the next cohort of residents that come in. I think a significant portion of your training is going to be done in simulation and in virtual reality, because it will add a multitude of different benefits. Reps, you can practice complications before you actually experience them on a real patient. And it eliminates what I'll talk about, which is our N of 1 experience, which is good and bad. So a couple things just to level set on some terminology. So you'll hear a lot of words thrown out: VR, AR, MR, which is mediated reality or extended reality. Really what these things are in aggregate are ways to augment human perception. And the hope is to deliver useful information in context at low latency. So how do you get that information to the headset, show you in a way that you can use it as you're operating dynamically in real time? So again, there's the real environment, and then on the opposite spectrum is virtual reality, where you're in a cave in a headset and you don't have the outside world presented to you unless it's synthetically recreated and presented. Then there's other things where there's pass-through, where there's augmented reality overlaid on the real world in front of you. And so there's a variety of approaches to doing this. Just briefly, the idea of stereoscopic vision's been around for quite a long time, and it really only made significant progress what is only 10 years ago. And so for those who don't know the history, it's pretty cool. This guy, Lucky Palmer, in his garage did a Kickstarter campaign. He raised $2 million from over 9,000 people, developed this dev kit. And then 2 years later, Facebook bought it for $2 billion. And that was really the start of commercial VR. So what is VR? Basically, it's two screens projecting an image so you can get a stereoscopic image. These are quite complex systems now. And early days, there was a lot of VR fatigue and nausea because you're trying to account for a visual system, which is obviously quite complicated, and how it's tied into the cerebellum and how our eyes move with balance and perception of the world. They're trying to mimic that essentially with the headset, right? So you're looking at roll and pitch and yaw, a variety of different things. They've gotten significantly better over the last number of years to where it's, getting to be where you can wear these for a long period of time. And because so much money's been put in and they've been commoditized, the prices come down significantly. So the current price of an Oculus Quest is $350, and the resolution's not bad. And so there's multiple players in the space. There's Oculus. One of the more interesting one is called Magic Leap. That's off to the right on the top. I'll show you in a moment. They're partnering with Brain Lab. The center is the one that was done by Microsoft. I'm not sure they're continuing with that project. And then it was announced this week that Apple's going to probably ship their first VR set by the end of the year. So how good are these things? So there were a couple interesting papers recently that estimated that human eye resolution is 576 megapixels. And if you look technologically, what's happening is that as with computer chips, they're scaling down the pixel size, and that's happening at a very rapid rate. So the size of the pixel and then the density per centimeter is increasing dramatically. And so there are already systems that are 108 megapixels, and it's estimated by 2025 that will arrive at systems that can do upwards of 576. Do you need this for an experience that may mimic like a Zeiss or Leica? I'm not sure, but the technology is going to avail itself to be able to do that type of resolution. So where is VR and MR useful for us in the future? So again, I mentioned simulation and training. It allows for repetition. There's a lot of interest in children's in case preparation and practice. It lends itself nicely to that. I think textbooks are going to be different in the future. You're going to immerse yourself in a neurosurgery textbook and watch and learn in a very different way. It allows us to use this in the operating room, and I'll show you just an example of that coming up. It hasn't quite gotten there yet, but it's getting awfully close now. And then this whole idea of telesurgery or telepresence, I'll touch on this at the very end. So how we learn, this is from a third grade teacher thing. Learning's complicated, right? And how do we learn, retain, receive information, repetition, recency of that information? All those things are germane for learning. And we are really stuck, I would say, still in a model of one-to-one teaching. So, while we've evolved from the picture on the left, this is on our website for our department, right? So there's someone operating with Dr. Ellenbogen. He's teaching them one-to-one, and they've got to memorize and remember and understand the unique pathology of that one-off case that they did that day and try and assimilate that knowledge for later. And nobody else gets to have the benefit of that teaching session, which is tragic in many ways, right? And I like this. This is the way learning happens. I think this is very true. We spend an enormous amount of time training a neurosurgeon. It's probably not practical as populations grow to be doing it this way. 4 years of med school, residency, fellowship, and I don't think you gain a mastery of our craft until you've been in practice for 5 years. You don't start day one when you're called an attending and you're like a master of your craft. There's no such thing. It's an experience that's gained over time. And we do focus a lot, even at a mastery level, of our N of 1. And we all talk about it And whether that's germane to the broader patient population or not, it's an experience that was emotional. And so we tend to teach to that. And maybe that's not the right thing. So there's a lot of companies that are getting into this space. So I know the CEO of this company, he was an orthopedic surgery resident. And what they've developed is gamified orthopedic surgery training. So you can go in and do a knee, a hip, or whatever. And they've shown that trainees and others gain significant transfer of skill using this type of thing. But it's gamified. And where this is going to go is we'll eventually get real data from the OR as we've extracted it to create these training scenarios. But this is sort of what it looks like. You come up, you know which instruments to pick, you go through the steps. And what the CEO said to me is it's the sequence of steps and knowing that matters. That's true to a large degree, but there's a lot of context that's lost that will be gained with the evolution of this. And it's starting to happen. Our friend Aaron Cohen-Goodall's got, Neurosurgery Atlas. He has a tremendous interest in VR and sort of how to bring these teaching tools into more realistic scenarios. People are starting to do CV and extraction within our space. And this is from Stanford's resident education website, where they're sitting there with surgical theater. Whether they're in the game room doing this every day, I highly doubt it, but this is an example of the thought process. And companies are aware of this too. So if you want to try a new piece of hardware, you can do that in VR versus going to a cadaver lab. So I'm going to end in these last couple of things. So the integration of MR and VR into the operating room is slowly happening. Surgical theater tried to bring this in and integrate it into the microscope. These are different technologies that don't blend well together. So the operative microscope, I think, will eventually go away, and we will be doing digital microscopy where these tools can be better integrated in. But again, it just shows that we desire these type of tools to help us in the operating room. The first FDA product that's really using VR is a company called Augmetics. They're doing spinal navigation. So you put on this headset, it shows you translucently where the spine is and your trajectories. They're FDA cleared and now on the market. Brain Lab, I mentioned, is partnered with Magic Leap, and they're actively looking to bring the system into the operating room. The second Magic Leap headset, if anybody's put it on, it's actually pretty nice. It's light. There's a battery pack that you wear. It's pretty darn good and getting close to a form factor that would come into the operating room. And they're taking that product through FDA right now. And this is us experimenting with this. This is an Israeli VR headset that I'm in. And so I'm seeing the fully immersive three-dimensional data that's projected on the screen there, representing sort of how we would do screw placement. So the final thing I'll touch on in the last minute or so is telepresence, right? So if you can digitize these scenes, you can then leverage network and transport that image live to another location, right? So many of us are interested in helping others learn and treat patients around the world. I just pulled this off of Vanderbilt's site. We do this. Many of the graduates of our program have been deeply involved in global neurosurgery, but this is not a scalable model, right? You fly, you leave your practice, you spend a week, you do a couple cases, you teach people, and then you leave. That's not a good model. So I had a great experience doing this with a colleague who reached out, wanted to learn rhizotomy from me during COVID. She couldn't come here. We used MS Teams to live stream doing a rhizotomy. So she actually live streamed the first case to me. I sat in my office for 6 hours and I proctored her through the case. Then we did this 6 times. I sent her images. This is her on vacation watching me operate with a wallaby or whatever in the background. It really worked. And now she's off doing these cases on her own in Australia. And we published this not in a journal, but in Fast Company. But there's companies now enabling this. So Immertech's one, they bring in cameras, you're in a VR headset. The one that's probably the farthest along is a company, Proximie, that is doing this type of work. So, this concept of how do we make better surgeons, super surgeons, I think it's really about building on innate abilities that people come to us with and that we all have. The opportunity is key, right? Like we tout our program as one of the busiest neurosurgery programs in the country. Why does that matter? Because reps matter, experience matters. who's teaching you matters, right? Like, so what training are you getting? That's going to determine how your patients do in the future. And this is a learned skill, right? Like, you got to do it to get better at it. And the reason you get better is you experience complications, you figure out how to work through those, get patients safely out of the operating room. So I didn't talk about robots today. That's a whole nother conversation. A robot is only as good as it can see. How are we going to do open and closed loop? Where's AI and ML come in? How are we going to interface with these things? That's a whole nother conversation. As is the issues around this, which I think are huge, right? Privacy, data standards. Who owns this data? Is it the patient, the hospital? Does the company own it? There's a ton of ethical and DEI issues around this, and certainly regulatory. As we start to have AI and ML and these programs are changing dynamically in real time, you can't have the FDA approving every change or iteration of these computer programs or the output. So how are we going to leverage AI in a highly regulated environment? And so I'll end with this quote. I think this is, pretty cool and very germane. I wonder whether any other generation has seen such an astounding revolutions of data and values as those through which we have lived. Scarcely anything material or established, which I was brought up to believe was permanent and vital, has lasted. Everything I was sure or taught to be sure was impossible or was possible has happened. So I think that's where we're at in neurosurgery right now. We are evolving from an analog 100-year epic of neurosurgery into the digital world. And the final thing I'll say is we have put together a new meeting that we're going to do in Palo Alto in October that we're calling Digital Neurosurgery. So the idea is that for those in our specialty who are interested in this space, we want to provide a place, an opportunity to learn and share where we think this world is going. And in addition to the normal partners we would have for a neurosurgery meeting, who all identify that digital is real and coming, we want to start to actually engage with the NVIDIAs of the world and the Apples and the Intels, because this intersection of computer science is what's going to drive us forward. So I would encourage everybody to attend this meeting and just reach out to me if you want more information about it. So with that, Rich, I will stop. I appreciate the opportunity to present it today. Thank you.
Thank you, Sammy. That was really entertaining. I really enjoyed that. A lot of fun. So let's take some questions, and I know some people have to drop off. It's almost 8, but Christoph, you popped on first, and then John Lozier second.
Hey, Sam, really wanted to congratulate. That was a great talk. I really enjoyed that. And I think, putting it into perspective like you did, this is rare these days. So thank you. 2 little things that I wanted to, bring to your attention. One thing is that I think I just talked to Christopher Ames, who, as you know, is a big deformity surgeon, and he fed all the data into his outcome database. And interestingly, the only thing that remained positive was 45 degrees of lordosis between L4 to S1. So I think we should remain open-minded, because I think the results that we're going to get are going to be very different from what we anticipate we will get, which I thought was fascinating. And the second point, I think, is that a lot of the overtime and efficiencies are not in the surgeries, but in between. So cleaning the room, turning over the room, having help giving you the instruments. And I think there's probably 90% efficiency that could be gained there. So I think it's really interesting that you're looking at workflow right now, but I think we should look in between surgeries too.
Agreed. Yep, agreed.
That's great. John David Lozier.
I thought that was a brilliant talk. Privileged to listen to it. What worries me, however, is we still are physicians. And if we focus exclusively on the technology, we're going to put the physician part in jeopardy. So as we move towards such a brilliant new approach, I think we need to remember that being a physician requires interacting with a living patient, not a part of a patient.
Yeah, no, thanks, John. I agree. I mean, I think it's incumbent on us to carry the humanity of what we do forward, into, this next epic, right? Because technology is going to be so, in some ways, overwhelming. And I think it's also really important that we still know how to operate, right? Because these things can fail. They may, to, you know, Christoph's point, they may tell us correct information, or they, you know, early on certainly may tell us wrong information. And so they are tools like anything else that we use, and the tools are getting better, and hopefully they make us better, but they should never replace us.